Audio good?
Yep.
Excellent, thank you. So just a couple of disclaimers or disclosures. I am speaking today not as a representative of Johnson & Johnson or of Ethicon Global Surgery, but in my capacity as a former practice leader and cancer program director and a CCC board member and president. So any opinions, et cetera, that I expressed today are my own and based on my prior experience, not from the device industry. And also I do some consulting for TaylorMed, just as a disclosure, again, in that capacity as a former cancer director. So what I thought I would do is just sort of share some observations. And one of the things I will say that's been a little unique about my current role is that it gives me a different lens to look back on what's happening now on the provider side, because we're a global company that has reach across the entire globe. We are constantly speaking with our customers, and so very much aware, especially in the surgical realm, of what's going on with health systems. It'll come as no surprise or news to anybody on this call that we are currently in very challenging times. Obviously, the COVID-19 pandemic has upended delivery of healthcare in many ways, both in terms of on the provider side, with deferment or cancellation of elective surgeries, with changing capacities within health systems in areas that are hard hit with the virus, to convert general med surg and other specialty areas, even operating rooms, to ICUs or to COVID-19 wards, repurposing of staff. So you have scenarios that we've seen at the worst where you would have surgical subspecialists and other subspecialists functioning as intensivists, and in some cases even as basically highly trained residents doing the bidding of their critical care colleagues who are much more experienced in managing ventilators and other critically ill patient needs. In addition, you have the issue of patient fear. So you have patients who are either deferring their elective treatments, in some cases deferring even non-elective treatments for fear of being in a hospital or an outpatient setting and being exposed to COVID. And certainly this has impacted, I think, care across the spectrum. And then on top of it, we have the huge increase in the ranks of the unemployed and thus the uninsured. And so those additional issues in terms of patient access and patient finances. So all of these things have sort of coalesced to certainly what one could consider a perfect storm. And then on top of that, lastly, you have the tremendous pressure that this has placed on the bottom line of healthcare organizations. As we all know, I'm sure many of you on this call are members of community-based not-for-profit health systems. And we all know that in that part of the healthcare universe, margins tend to be fairly slim, sometimes non-existent. And so certainly what we have seen over the past several months is healthcare institutions that have seen a strain on the balance sheet, a strain on the income statement, and so already stressed organizations have been increasingly stressed. So certainly not the rosiest of pictures in 2020. I'm hoping that 2021 will be better, and like most of you, I can't wait until this year is over. I'm hoping there'll be something better on the other side, although time will tell. So clearly this creates a tremendous number of challenges for health systems, and specifically to talk about cancer programs, what are the things that program directors and executives need to be looking at? And I think there are several things that you need to do. First, I think, is to think outside the box. I think that in unprecedented times, this calls for all of us, and we've seen this on our end in the device and the pharmaceutical industry, being creative, being open-minded, being willing to do things that perhaps you would not have done before, so long as you vetted them appropriately. And I think that if you do that, then there's a chance that you'll come out of this on the other side in reasonable shape. And at the end of the day, first and foremost, we always have to keep the patient in mind. So what are the things I think that cancer programs need to do? I think that leveraging technology is going to be extremely important now and going forward. And when I talk about that, I talk about that in a broad sense. So I have friends and colleagues who are in other spaces, in software and in devices. And so starting to look at ways to monitor and engage with patients. I mean, we've all seen the tremendous uptick in telehealth. And I think that that is going to be an important lever and an important tool for cancer programs going forward. Not only just telehealth for things like visits, but as we all know, there is a lot of activity in terms of symptom management, symptom monitoring, engaging with patients, and communicating with patients in ways that keep them out of the ED, keep them out of the clinic for issues that may be resolved at home, and certainly keep them out of the hospital. And so I think those tools are going to be increasingly important. The second area in terms of technology is going to be being creative in terms of working to get patients their care, meaning there are 30 million some new unemployed people. We have patients who no longer have access to health insurance, but at the same time, we have to be able to deliver care to those patients. I mean, if you're in a not-for-profit health system, you never want to be in the position of denying care to a patient because of a lack of coverage or a lack of resources. And so being able to leverage both your in-house resources, whether it's social work, financial navigation, or looking to partners who can help you do that, is going to be very important. And I think that with health systems being somewhat strapped in terms of their balance sheet, in terms of their income statement, their P&L right now, I think an openness to looking at relationships and leveraging technologies and outsourcing will be an important thing for health systems to consider, because at the end of the day, it's going to be difficult, I think, for health systems to take on additional headcount, to take on additional expense, but at the same time, you've got to have the resources to be able to get your patients into treatment, get paid for that treatment, and minimize financial toxicity to those patients at the end of the day. And then lastly, I really think it's all just about flexibility. I think that we are in unprecedented times, and whether you're talking about financial navigation, symptom management, telehealth, not even starting to get into logistics of doing infusion in the COVID world, and what are the things that you need to do to make sure that patients are not anxious when they are getting infusions and other treatments, and to make sure that they feel safe, and also to protect your caregivers is going to require both some imagination, some due diligence, and some creativity. But I think at the end of the day, I think if we keep in mind the fact that we all have a mission, which is to provide high quality cancer care to our patients, the fact that we do have tools out there that we can use and leverage, and that at the end of the day, I like to think that we are all dedicated, creative, smart people that will do what we need to do to get the care to our patients. I think we can get through this, but I also think at the end of the day, it's going to be important for organizations like ACE, like ACCC, to serve as learning platforms and forums, and platforms for cancer program leaders, clinicians, administrators, financial people, to share best practices and to help one another get through what I think is a very unprecedented challenge. So with that, I'll stop and see where we go from here.
Thank you, Dr. Severman. Anyone have any questions? And just a quick reminder, you can submit your questions on the GoToWebinar control panel under the questions tab. Okay, no questions so far. So at this point, we can turn over to Michael Trapiani.
Hi, thank you for that. I'm gonna take over screen sharing. We're good? You guys can see my screen? which is the question that's asked 95 million times a day. So thank you for inviting me to this and allowing me to speak. It's a unique perspective to see this happen through, patient financial services. Obviously, we receive the updates from clinical staff, and we see what's going on, but we also see it from a different area as well. We see patients firsthand losing insurance. So it was also kind of a trip to go back to March, which feels like it took place 5 years ago instead of 5 months ago. But without further ado, I'm going to dive into it. I'll do a little bit of introduction about MSK, what New York City went through, and then what MSK went through. So it probably helps if all right. So MSK is located, main campus is on the Upper East Side in New York City. We have locations throughout New York City and in Harlem and Brooklyn, Long Island, the metropolitan New York, with also Westchester County, so New York State, and then also New Jersey, closer to the east coast of New Jersey to capture that patient population. This is our research building up on main campus. This is the main entrance to MSK. This is our Westchester site and our Bergen site, which is the most recent site that was open. So I just wanted to give a quick visual as to what the system looks like. What our hospital looks like and its regional sites. Quick overview of the services, our supportive care team and the treatment team. This is some, information that we provide our patients upon registering with MSK, so they know what is available to them. I wanted to put this slide on here because this slide struck me. There are thousands of strains of cancer that roll up into these cancer types, and these folks were forced to sort of kick the can down the road with their cancer treatment. I wanted to throw it up there because it was impactful as I was looking through information to put on this slide deck. It was impactful to me. This is from our annual report. This is a 5-year growth for our outpatient visits. It shows the differentiation between our Manhattan sites and the regional network, which I showed a few slides ago. And you could see that growth over time. And we, over the past decade plus, we invested pretty significantly into regional sites. That ended up working out really well for our patients as COVID hit and they didn't want to come into New York City. I wanted to put this on here as well. So everybody's heard the term, it takes a village. And like most hospitals, it's a very large village to kind of combat every single challenge that came up as it relates to COVID. So, the numbers are pretty significant for a cancer hospital. All right, so this is how coronavirus hit New York City. So it kind of spread like wildfire. You've got the end of February, first case of person-to-person by March 3rd reported. You've got 16 cases by March 9th, and then 17,800 by the 25th, with almost 200 deaths. And then it just continues on. And then by April 1st, the 5 boroughs of New York City looked like this. This was pretty significant. I was glad that the New York Times had this graphic, and I was able to pillage it for the purposes of this presentation. But this is pretty impactful. By April 1st, New York City was reeling. Of course, during the month of March, we also had, you had the first case reported at the beginning of the month, and by the end of the month, you had refrigerator trucks parked outside of hospitals because each individual hospital's morgue was just overwhelmed. And then, of course, we had the USS Comfort, the floating hospital that ended up in New York Harbor. So we did have a lot of support to try and mitigate some of this. Just as an example of a field hospital that I previously mentioned, the Javits Center is a sort of like a conference center on the west side of New York City. This is what it looks like from the outside. This is them setting up, to prepare for overflow from hospitals, and this is them in action. So shifting from New York City over to MSK, we saw a timeline of what New York City looked like, and this is how MSK responded. So by the beginning of February, we activated HICS, our Hospital Incident Command System. And then throughout the month of March, we started to take action that I think a lot of other hospitals took action on, canceling seminars, banning all of foreign and domestic travel, and our visitor policy was restricted to 2 people and later completely eliminated with the exception of pediatrics and end-of-life patients. By 3/13, all staff were set up to work from home, and that's very indicative of how hard our IT staff worked. And then through, schools began closing, we started rolling out symptomatic employee testing. All non-critical appointments started to get rescheduling. I had lost track of the fact that we suspended all research operations so early in March. And then, we start to see the growth of COVID positive patients at MSK. At its worst, we had 111 COVID positive inpatients with 32 in critical care. So that's 22% of our hospital beds were COVID positive. So we turned entire floors into COVID only patient floors. Right now, we have less than 1% of beds that are COVID positive. I wanted to show this slide as well because this kind of lends to the impact of telemedicine. You could see here, and I hope you guys can see the arrow going across the screen, that we never really wavered that far from like a 65-35 split between Manhattan and regionals, and that is because of telemedicine. You could see in April we were about half of what our volume of what we were in January. But you can see, again, how important telemedicine was. Whereas with chemo, we started to burst at the seams at our regional sites because nobody wanted to come into New York City. So, of course, you can't do telemedicine for chemotherapy. And you could see it shifted from a 50-50 split by the end of the year to by April, we were 65-35. That's a pretty big swing, especially for this volume of chemo appointments. This is just the same exact information from the previous slide, just in visual format. I thought it was, you could see that the total visits go down for outpatient, but the relationship between Manhattan and regionals kind of stays the same. And then you can see the shift over time with the chemo visits on this slide. This was, so my area of focus is high dollar chemo authorizations. I manage other authorization areas, but this utilizes most of my time. We have never seen anything like this. I've been in this role for 2 years. We normally operate anywhere from, between 13 and 1,500 cases, new cases a month. And we haven't quite come back to those levels, but we are starting to see some return to normalcy, hopefully across the U.S. soon as well. One of the other authorization areas that I oversee is OTPT. Of course, these are patients recovering from physical cancer-related issues. In April and May, we were at 0 at our 515 site. In July, we were up to 23, and previous year we were at 2,000. So, I mean, that's a pretty big drop that hasn't returned just yet. So moving on. So I didn't want to just kind of like talk about the impact on the negative side of things. Patients did forego treatment. We had lab research shut down. The financial impact is significant, and the true dollar amount isn't going to be learned until probably later on this year, probably next year. Clinical trials were limited. We did have an interesting unintended consequence with authorizations relating to radiology and chemotherapy. So because volume dropped so significantly, we were able to start offering next day imaging for our patients. Well, it takes longer than a day to get an authorization for radiology, so we started actually losing revenue there as well. And of course, like many other hospitals, some folks in our leadership positions were hospitalized with COVID, so we sort of lost that area of expertise as those folks were recovering. Positive impact at MSK. So MSK's board of directors and its employees contributed to an MSK employee relief fund, which gave out $2.5 million in help to MSK employees, whether it was childcare related or otherwise, a spouse that was laid off. Established food drives. We were able to continue our charity care or our free care for patients. Our copay assistance program expanded. I'll talk about that a little bit later. And I already mentioned about working from home. We expanded the prescription authorization program. This is take-home drugs. So this way our nurses didn't have to focus on that anymore. So we were able to expand that staff to take that away from the nurses so they can focus on other things. And overall job satisfaction, and people really had organizational pride throughout this ordeal, despite what they were going through in their own lives. So our immediate response, of course, hiring freeze. We expanded our authorization areas because our staff had additional bandwidth. For drugs that we previously looked at as a cost of doing business, we expanded that and we started going after everything. We shifted to telehealth. The federal government loosened restrictions on telehealth, and many commercial insurances followed their lead. In April, telehealth visits were 310% higher than pre-COVID baseline, with a one-day average of 431. In May, we averaged 1,000 a day, with a single-day high in May of 1,700. So the shift to telehealth was significant. We began shifting to subcutaneous administration routes for chemo. So like trastuzumab and rituximab, they have this a route available. It changes time in the chemo chair from hours to minutes, of course, reducing potential exposure to COVID. Also, other drugs, we were able to shift to increased dose and decreased frequency. So drugs that were given every 3 weeks, we gave them every 6 weeks and doubled the dose, and that was received favorably by patients. Pegfilgrastim, which is a very commonly used drug for cancer care. MSK established a policy that regardless of payer policy, we were going to allow on-pro usage. And on-pro usage means once they're done with chemo, they have this device put on, and then it shoots the dose into their arm 24 hours after they finish chemo. So they do not have to leave their house to get this drug. Again, expanded our copay assistance program. We did restrict new visits, but we did it in a way where a committee was established to ensure that we weren't hindering care or we weren't putting the patient at risk. Our physician sort of reviewed and decided whether or not it was the patient could wait, essentially, just to try and reduce volume. And to promote social distance within the office, we repurposed offices. Myself and my division are all home. We all gave our offices away for IT so they can be socially distant. And we also began utilizing Google Voice. And frontline staff were not comfortable using their own cell phones. So thankfully Google Voice afforded that opportunity. And oddly enough, some people lived in a very limited cell phone coverage area. And then finally, we brought cancer patients in from surrounding hospitals. This is to free up beds. We're not a general hospital. We freed up beds without insurance barriers, even if they were in network or not. And we cared for those patients so those hospitals can continue having freed up beds for their COVID patients. As a quick aside, our scientists have adapted their research to improve prevention, diagnosis, and treatment of the virus, focusing on implications for people with cancer. And we also, during this time, developed our own COVID test. I kept mentioning that we expanded our copay program. You can see the total of enrollees here, versus 2019. So this is indicative of folks that needed more financial support. And then this is the amount of money that patients saved. Overall, it's about $12,000 per patient, which is certainly not a small amount of money, especially right now. Our long-term response, so our regional sites will continue to operate at capacity. We continued expansion of MSK's IT group we refer to as Digits. So patients will want a mixture of telehealth and in-person visits. So expanding our telemedicine infrastructure investment required to transition thousands of employees to full-time work remote, and the financial implication of that will continue to be substantial. And this is why we don't know the true impact or the true cost of the hospital just yet. And then, of course, we asked our staff to do daily checks and self-checks. We implemented Adobe Forms, and I know this seems like a very insignificant thing, but we removed all the pens from the hospital. We didn't want people sharing pens. So, and I know a lot of hospitals followed in that as well. So registration forms were no longer filled out in person. We required everything to be filled out through Adobe Forms. And, you know, TaylorMed has kind of stuck with us throughout this process. We actually did our first IV copay patient during COVID, thanks in large part to TaylorMed and their willingness to continue working with us as the scope of our project changed over the past year, and also to help us identify those patients. So, I mean, it's been, we were very, very happy. We've been trying to do IV copay. We've been trying to get it going for about 3 years, and figures we do it during COVID. And then we moved up other existing hospital initiatives that we had in the works. You know, we talked about work from home. We got more comfortable. We do have offshore teams getting authorizations. We allowed them to work from home, which was previously not something that we allowed to do. ACD is a call center type phone service. We figured out that we were able to get that going at home, so those folks can continue to work at home. And then we started releasing non-MSK owned real estate. So we have expensive real estate and you know, in Midtown Manhattan, and we started releasing floors in some of those buildings. Lessons for the future. You know, I think for you know, an institution of this size in terms of employee population, like we can handle other items that will shut down New York City, like, you know, terrorism and climate and air quality and maybe another pandemic. You know, we have seen that telemedicine is a viable way to care for patients. And then sort of like, as it relates to people, you know, our staff members are in tiny apartments in New York City and used to refer to New York City as their own backyard. And now they're trapped sort of in their own apartment. So, and we had like many people, we had a staff member who had COVID. Her dad had COVID. Unfortunately, she lost her dad. She was dealing with trying to ship the body back to her home country. And, you know, I checked in on her with an email, and that, you know, looking back on that wasn't the right approach. I mean, I should have picked up the phone and called there. So like, for those folks that are sort of, you know, trying to keep their kids off of their video calls and everything, like, I think checking in on a call is the right way to go. And then don't force video calls. They can be exhausting. So those are sort of like individual, like, people things that we learn for the future. And then my final remark is that mask, social distancing and quarantine works. This is the number of cases announced each day, and these are the number of deaths. So it was working, and that's all I have. I wanted to put up my my information slide again in case anybody has any questions beyond this presentation.
Thank you very much, Michael. And we do have a couple questions that have come in. And then just another reminder, if you have questions for Michael or any presenter, you can just post those on the questions tab on the control panel. So the first question that came in is your oncology outpatient department, i.e. infusion, rad-onc, currently treating COVID positive patients?
Yes, we are.
Okay, and then the follow-up to that question is, what COVID management medications are they administering in the oncology outpatient setting?
So I'm going to leave my information up there, so I don't have a good response to that. But if you want to email me separately, I'll find out the answer, and I'm happy to share that. Okay.
And then another question that has come in is, have you been able to leverage virtual visits for new patients?
Yes. So that's begun as well. So all of our, you know, from nurse practitioners to APs to our physicians are all starting to leverage that for new visits as well.
Okay, thank you for that. Any other questions for
Mike?
Thank you. We move on.
Actually, if I could make one comment, I wanted to pick up on two things that Michael said that were very important. I mean, I think that, you know, given the fact that people on this call are in leadership roles, I think you made a very important point about checking in on your team. Something in our organization that we have really embraced in terms of regular check-ins by phone, by video conference, to make sure that everybody, and obviously, you know, you tailor it to your specific part of the organization, because obviously MSK is a huge health system, but you know, within your teams, it's important, I think, to make sure that you maintain contact with your folks in these stressful times. And the other thing that you meant that I saw in your presentation, Michael, I think it's important and is going to, I think, may haunt us down the road, is not only were we seeing deferral of care, but we were seeing deferral of screening. And I worry about both the patient impact in terms of outcomes and upstaging and late detection, and obviously also what that means for us as a health system in terms of rendering care to those patients.
Right.
Okay, it looks like we've got all our questions answered for Michael. Thanks again, Michael, and I will now turn the presenter
Thank you.
to Shrulik.
Thanks, Brian. Just verifying, can you see my screen? Great. So first, pleasure to join Dr. Soberman and Mike in this panel, and thank you very much for you, Brian and Ace, for hosting this very important event. I would like to kind of take a few words to introduce myself and Telomed, and then share a few of the perspectives that we are seeing in the technology ecosystem as a result of this unprecedented times. So as you mentioned early on, I'm the co-founder and CEO of Telomed, a health IT company that I co-founded about 4 years ago, following being the caregiver of 6 members of my family who were diagnosed with cancer. My background came from medical device, spent almost 10 years in a device company that developed a modality for treatment of ischemic stroke patients before starting Telomed. Telomed is headquarters in New York and in Tel Aviv. I'm currently speaking from Tel Aviv. Our Newark office is currently closed. And actually here in Israel, we kind of came back into the office just a few weeks ago. So that was definitely great to kind of reconnect with our team. Our company currently serves more than 40 hospitals and 200 clinics across the US, with some partners that are currently on the call, as well as others, both in oncology centers and also more broadly across different therapeutic areas. Our initial approach was to find ways to alleviate financial burden for patients, while also being very conscious about provider revenue collection. And we developed a very comprehensive product, actually a platform that screens for patients from the EMR and billing systems to both project their out-of-pocket expenses, as well as to find ways to alleviate their financial concerns by leveraging different opportunities like financial assistance program, government subsidies, and even optimizing their insurance plan. Thankfully, we've been able to partner with some leading institutions to show that value, both for thousands of patients a year so far, and so far approved north than $150 million in savings to those patients, and as a result of that, to the bottom line of our provider organizations. So that's kind of a few words about Telomed and myself. I wanted to kind of take a step back. I think, Mark, you mentioned the term perfect storm, and I think that COVID-19, the pandemic, definitely is a perfect storm, but also for digital acceleration. I saw a headline in the New York Times a few months ago, basically describing the pace of change that we are seeing, getting us to see like 10 years of change in 1 week. And I think that what we're experiencing, both as individuals and definitely as people working in the healthcare space, is that technology, innovation, and some solutions that were kind of on the back burner and just starting to penetrate our day-to-day have completely taken over our lives, our workforce. We are currently talking, I think, through WebEx, but definitely those tools have become like a second nature and an extension of our day-to-day to communicate with peers, to communicate with patients, and obviously to communicate with family members who are sometimes away from us. So for sure, we have seen a very quick change to how work is being done. We are seeing a change that was described by both of you, Mark and Mike, related to care delivery. I think that we are seeing an adoption of telehealth that was, kind of a novel idea just a few months ago that was starting to be adopted in some areas of care, but now that has become like the dominant care delivery tool for many of the visits that can be avoidable. And more to the point on this discussion today, we are also seeing changes to how cancer care is being delivered. And I think that one of the things, as someone looking from the technology and industry perspective that I wanted to share, is that I think that the partnership that is being built between health systems and providers in general and technology companies to understand the specific needs that are arising now and will potentially stay with us after the pandemic is very important. And I wanted to kind of give a few examples from what we are seeing in the industry nowadays. So I'm sure a lot of you have seen, like a couple of weeks ago, there was a huge merger in healthcare IT between one of the leading telehealth providers or vendors to Livongo, who has built a remote coaching for diabetes and chronic condition, an acquisition of around $18 billion that basically tries to combine two leaders in virtual care, kind of giving us a glimpse into the future of how care delivery would look like to individuals who are experiencing chronic and critical conditions. We are seeing both the virtual physician and remote consults as something that will be potentially staying with us after the pandemic as well. But obviously, we'd love to hear your thoughts about that afterwards. And also how to engage with patients in different points of care throughout the continuum is something that I think that this is kind of an example to movements in the field that we are seeing. Another example I wanted to share is something that is more related to cancer care delivery. One of our partners, Philips, and some others in the field are taking virtual tumor boards and allowing connectivity between physicians in either metropolitan areas, but also some in remote areas, and bringing collaborative decision-making into the hands of physicians that not necessarily have the ability to meet with their peers for what's, I'm guessing, a standard day-to-day tumor board meeting at the hospital and doing that remotely or virtually, but also to bring the depth of knowledge and experience of leading cancer centers like Dana-Farber, who is partnering with Philips around clinical pathways, or MD Anderson for that matter, at the hands of those clinicians who are providing care in different provider settings, and having the cutting edge clinical decision making provided at the fingertips of those clinicians. So just giving us two examples of how technology is driving care delivery changes and how it is bridging geographical and actually social distancing challenges that we are seeing before, but definitely in a faster pace during the pandemic. I wanted to also talk a little bit about what you mentioned before, Mark, related to provider financial viability. I think that we have seen the challenges for providers even before the pandemic, but with the fact that many healthcare systems and practices has completely ceased or drastically reduced the elective procedures and services, and that is making a very strong hit on their revenues. We're trying to look at how technology can become a driver to increase the financial viability of provider organizations. And just to give you a couple of categories that we are seeing out there, one is how to automate labor-intensive processes. I think you also alluded to that around authorization, Mike, but also some of the outsourcing trends that you have mentioned earlier, Dr. Soberman. So we are seeing that processes that are very labor-intensive, like prior authorization, even EHR documentation, or the very mundane task of scheduling, are now being empowered by different types of advanced tools to help increase the automation level of those processes, as well as to bring ways to reduce the staff required to carry out this very expensive task sometimes. And in another perspective, also looking more specifically into the revenue cycle stream and how technology can drive automation on the one hand, but also to simplify the process for patients. Because if you look at denials, for example, and automatic prior authorization can address that. But I think that in general, the collection process from patients is something that we are seeing a lot of movements with companies like Cedar and others that are trying to provide something that we are becoming very used to in our day-to-day life, using our smartphones to make payments, and bring that into the healthcare system and to the healthcare space, both in order to simplify how patients are supposed to be paying for their care, but also to increase the revenue collection efficiency for healthcare providers. And last, basically touching a bit more into what we are doing here at TaylorMade, is how to identify other resources of revenue that can alleviate both the financial toxicity on the patient side, but also to increase the financial viability on the provider side. And I think that one of the things that we are seeing, and very glad to be partnering with teams like the Memorial Sloan team, is that teams are aware of those opportunities like co-pay assistance programs, governmental assistance programs, and so forth. But it's very hard to find how to leverage technology to find the right patients that are most financially vulnerable and address those challenges as early as possible in the patient's medical journey. And I think that this is another example of how technology can play a significant role in helping providers essentially help their patients. As a last slide, I wanted to talk a few words about how we responded to COVID as a team. I think that first we saw that the users of our system across many health systems in the country are now starting to work from home, and it seems to be a very straightforward request, but having the ability to continue to comply with all of the strict security and privacy regulations while allowing a smooth transition into working from home was one of the first things that we've put our efforts on. Another one, very quickly, at the beginning of March, we saw the emergence of a lot of new resources dedicated to both COVID-19 patients, but also patients in general that have been impacted financially from the pandemic. And we started curating a database that is now inclusive of, like, I think a few hundred programs that we are both curated into our system, but also sharing publicly on our website. And you have a link here that you can freely use of programs that can address out-of-pocket expenses for patients for their direct medical bills, as well as other expenses related to transportation, living expenses, and others that are part of the financial impact the patient can have. I mentioned before, one of the things that we have been doing even before the pandemic that have been more significantly needed now is the ability to project out-of-pocket expenses throughout the episode of care and use that in order to find the patients that have the highest financial risk and engage with them as early as possible in the medical journey, and basically be more proactive about helping patients, and as a result of that, secure the revenue collection, but not from the patients in that case, for the healthcare providers. And last but not least, again, telehealth was mentioned before. We have been adopting that as well as part of our services offering to be able to connect with patients at their homes through phone calls, through Zoom sessions, and basically allow for the full financial counseling or financial navigations process to take place without being present and not requiring patients to come into the practice. So that's kind of the thing that we have responded very early on and continue to do that, that I wanted to share. And with that, I think that I'd be happy to take any questions if there are any, or to kind of ask you a few questions, the people on the panel.
Thank you very much, Shulik. We did have a question, and I think it was directed for Michael, but we moved along a little too quickly. So the question that came in was, do you have to be part of a licensed group that gave you the approval to approach new clients for their first visit?
Do you have to be, I just want to make sure I understand the question, part of a licensed group to approach, I'm sorry, can you just repeat it one more time?
So do you have to be part of a licensed group that gave you approval to approach new patients for their first visit?
We don't, I just want to make sure I'm answering this correctly. So we don't approach patients for their first visit. They come to us. But if the question is surrounding, the tools that we use to do telehealth visits and be able to have that first visit, then yes, we made sure we put everything in place to protect patients, to protect the patient's data and information. I don't know if that answers the question.
Thank you, Michael.
All right.
If I may, maybe one question to both of you, Mike and Mark. We're speaking a lot about the changes that are taking place now during the pandemic. And my question to you is, what do you envision will stay once things hopefully come down? And what of those practices do you think will be part of cancer care delivery for the long run?
So I'll start, I guess. I mean, I think that certainly we're going to see more telehealth. I think that genie is out of the bottle. And so I think we're going to be leveraging that a lot more, not just in cancer care, but across the board, for one. And I think that will probably spawn increased adoption of other technologies along the lines of online navigation, patient call centers, triage, all these things that we can do to interact with patients in a very personal way, but at the same time, not necessarily face-to-face, to be able to minimize that exposure. And then I also think that we're going to see a lot more work from home. And it's going to affect, unless you are a patient-facing individual, a caregiver, something along those lines, I think we're going to see more of that. I mean, Michael, I think what you guys did at Memorial, the whole Adobe Forms thing is brilliant. I mean, you got pushed into that to some way, but why on earth are we having patients fill out paper? I mean, that's just stupid in 2020. And I'm wondering how many of us are going to go back to the office at the end of the day. I mean, I miss being in the office, but I've been remote since March. Most of Johnson & Johnson's 150,000 employees are remote, including our CEO and chief medical officer. And so it's going to be interesting. I think that work as we know it is going to be a little different. And I think we're going to try and I think some of this is going to stick.
Yeah, I think that, I mentioned during the presentation, there was a drug called pegfilgrastim or Neulasta Onpro, and subcutaneous versions of some certain chemotherapies. I think hospitals and hospital systems are going to start creating those carve-outs in contracts with payers that don't normally allow it. It is literally the difference between minutes in the chair, the chemo chair, or hours in the chair. And beyond COVID, I mean, patients don't want to spend, they have so many doctor's appointments as it is. They have so many services that they need to tend to. paperwork, filling out financial assistance forms, and going here and there, and they don't want to sit for a full day in a chemotherapy chair. So I think that that's one thing that I think this is more of optimism than maybe what will actually happen. But I do hope that health systems are carving those opportunities out in their contracts. I mean, it's seriously beneficial to patients.
Thanks. And maybe one last question if we have time, unless we have questions from the audience, Brian.
We have one that came in, Trulick, that I can ask right now. So this just came in. How do you think technology will change chemo delivery?
That is a really good question.
Yeah.
The daratumumab subcutaneous version came out during COVID. So that's another drug that was started to be administered in that and with that administration route. I think developing of these drugs and at pharmaceutical companies is I think that's where we're leaning on the technology for delivery of chemotherapy is increasing the ways in which these drugs are administered. Not every drug could be administered with a take-it-home pump. But because I think they want to be near their hospital. I think they want their chemotherapy I'm not saying anything that everybody on this call doesn't already know, but it has some serious adverse effects. You don't want to be given chemotherapy at home without somebody around. So I think that the administration route has to cut the time of how long patients are sitting in chemo chairs. And I'm sorry I keep going back to that point, but I think because of the longer that you're outside your home, the more exposure you have to COVID. I think that's going to be a positive consequence of all this.
And Michael, to your point, I wonder, there has been some development over the past couple of years of the concept of the hospital at home, with acute care, even with appropriate remote monitoring and video, and home health and visits and nurses. And I wonder, perhaps, I don't know, but, if we get to a point where perhaps the toxicities of some of our intravenous infusion drugs will be sufficiently mitigated that we can even migrate some infusions to the home with appropriate monitoring, wearables, remote monitoring, those video, right, those kind of things, as long as we don't run into problems with failure to rescue, with someone who has a significant event.
Yeah, and even these, the only on-body injector that I'm aware of is the pegfilgrastim. Other supportive care drugs. The technology should roll out to beyond that. Folks don't want to continue coming into the office just to get an injection for severe diarrhea or colitis or everything that happens as a result of chemotherapy. So I do think I do hope we see more of those things that can fire on your body while you're at home, and then you take the thing off and go about your day.
Okay, any other questions for our speakers today before we wrap up? Okay. Okay, well, I would like to have a big thank you to our speakers for today, and also to TaylorMed, and also for all of you joining the call today. I'd like to just announce too, we have our next webinar coming up in the COVID-19 series. It's going to be on August 27th at 1 p.m. Eastern. And the topic is how Seattle Cancer Care Alliance optimizes nursing capacity across multiple specialties and spaces. You can find more information about that and registration on cancerexecutives.org. With that, I'd like to close for today. So again, thanks to our speakers, and hope you all have a great week.
Thank you
very much.
Thank you.
Bye, guys. Thank you.
Take care.
Keep safe.